Good evening, Dr. Kopi, Dr. Kweki, and all consultants and seniors on the call and colleagues. Once again, we continue with guidelines. Today, we'll be looking at the 2023 ESC guidelines on acute coronary syndrome. So we go by the usual, we are going to use the ESC, so we need to know the definitions for the classes of recommendation. This is an area emphasis. We already know what the classes mean already. So class 1, we all know is recommended or indicated. Class 2, class A and 2B, 2A meaning to be considered, 2B may be considered, and 3 definitely is not recommended. Then the levels of evidence as defined by level A, B, and C, meta-analysis, multiple randomized trials for level A, single randomized clinical trial, large non-randomized studies for level B, and C is consensus of opinion of experts or small studies, retrospective studies, and registries. So essentially, we all know that acute coronary syndrome represents a spectrum of 3 main conditions, which mostly is referred to as unstable angina, non-STEMI, and STEMI. And patients can present with varied symptoms, but most importantly, what runs across them typically is chest discomfort, which can be described in several characteristics. It may be pressure, heaviness, burning sensation, etc. And the presentation can be influenced by the age, gender of the patient, and other comorbidities. For example, an elderly patient may present without the typical sharp chest pain, substernal chest pain, may present with burning sensation, out females or diabetics. So these are, we need to know some of the things that may influence the presentations. The patient's presentation, the first time a patient may present with ACS may be cardiac arrest or acute left ventricular failure. So the patients may present with complications. And what will differentiate the various subtypes of acute coronary syndrome, essentially, other than the presentation, is the ECG. And if the ECG is normal with no ST elevation, then it falls under a group called non-ST elevation acute coronary syndrome. And if there is ST elevation, then you can say there's STEMI. Now, for the non-ST elevation acute coronary syndrome, depending on your troponins, then you can have a final diagnosis of unstable angina in which your troponins will be normal, or it becomes NSTEMI in which there's no ST change elevation. You may have normal ECG or ST depression with elevated troponins. This is for re-emphasis. So if a patient reports with history suggestive of acute coronary syndrome, mostly chest discomfort as stated, ideally you need to perform an ECG within 10 minutes of the first medical contact. Then the ECG will help you classify the patient as having a STEMI or a non-ST elevation acute coronary syndrome. And when the troponins comes, depending on whether it is elevated or not, you can reclassify the non-ST elevation acute coronary syndrome into unstable angina on an NSTEMI. And at the end, this patient may actually be excluded from having an ACS. It may be a non-acute coronary syndrome diagnosis. So always you are looking at the abnormal ECG in the right clinical context. Then you also ask yourself, is my patient stable or not? All this will inform the path you take. Now, if a patient comes to your facility with chest pain, and you think this chest pain is acute coronary syndrome, and ECG shows ST elevation and is consistent with STEMI as defined by the ST elevation. If you have a patient less than 40 years, then you're looking at a minimum of 2.5 millimeters in leads V2 and V3. In any other leads, we are looking at 1 millimeter for male. And if it is male more than 40 years, we are looking at 2 millimeters in lead V2, V3. If it's female, we are looking at 1.5 millimeters in V2 and V3. So these are things that we know already, but just for emphasis. So you say this patient has STEMI. Now, what do you do? So if the patient is reporting to a facility where the facility, So if the patient is reporting to a facility where the facility can do PCI, so if the patient is coming to this facility where the patient can do PCI, and you, 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 your pathway for this patient will be to revascularize with a primary PCI because that is what your facility has been resourced to do and is reporting to a primary PCI center. So that is the pathway you take. Now, if the patient is being seen at a facility that does not have PCI, but a diagnosis of STEMI has been made, the question you ask yourself is, okay, how far away is the facility that can do PCI? Is that facility less than 2 hours or 120 minutes or more than 120 minutes? If that facility is within 120 minutes from the first medical contact, your facility that you are seeing the patient, then because primary PCI is superior or has better outcomes compared to thrombolysis, your preferred goal is to get this patient to have primary PCI. So you refer the patient for primary PCI, as you could see. However, if the place where they can do the PCI is more than 120 minutes away, meaning you can't get the patient to that facility within 120 minutes, then what you do is that you thrombolyze the patient if there's no contraindication for thrombolysis. Then refer the patient for rescue PCI if indicated. So that is the pathway. So comes with a chest discomfort. You think it's an acute coronary syndrome. You do your ECG, ST elevation, STEMI. Can I do STEM in my facility? Yes. So you go to primary PCI in your facility and you're aiming for the wire crossing at less than 60 minutes because it's a primary facility that's where the patient reported. If your facility cannot do PCI, you ask yourself, which facility can do PCI? And facility B, how far away is that facility? If it's within 120 minutes, you want to refer the patient for primary PCI. Okay, and that one, your door to needle, we are looking at maximum 90 minutes. Now, if the facility that can do PCI is it's not within 120 minutes, then you have to thrombolyze the patient, and if there's no contraindication, and refer the patient for rescue PCI. So this is a general overview before we go to the guidelines. Now, if you have a patient who is having a non-ST elevation acute coronary syndrome or non-STEMI, essentially, then you have to re-stratify your patients. That will define the pathway you take. Is my patient very high risk or is my patient high risk? And there are things that define your patient as very high risk or high risk. Now, if your patient is very high risk, as defined by evidence of the parameters described above, then you treat your patient just like your patient has STEMI. If your patient has high risk based on your evaluation, then you have to send the patient for PCI within 24 hours, which is defined as the early invasive strategy. So for very high risk and non-STEMI or non-ST elevation acute coronary, you treat them like STEMI. You want to get them immediately revascularized. If it's high risk, then you have to get the coronary angiogram with possible PCI within 24 hours. If they are not high risk, low risk, then the recommendation, as we'll get to know, is to, based on the risk stratification, do the angiogram, at least the diagnostic, before patient is discharged from the facility. That is if your facility can do that and patients can afford. So this is basically a summary of when a patient comes and you're thinking it's acute coronary syndrome in the context of the ECG history and the stability of the patient, i.e. the stability of the patient is what will help define your risk of patients, especially if you are dealing with a non-STEMI. Is my patient in heart failure? Is there pulmonary edema? What is the blood pressure? Is the patient hemodynamically stable? Is there ongoing chest pain refractory to treatment? Are there dynamic ECG changes? Is there a new mitral regurgitation? What is the grade score of this patient? This together helps you, together with the ECG, make a decision. It's a STEMI, or it's a very high risk non-ST elevation ACS, or it's a high risk non-ST elevation ACS. If it's a STEMI, you know you're going for immediate revascularization as your option. Preferably, patient is reporting within 12 hours. Beyond 12 hours, there are indications to still go for immediate revascularization in STEMI, which we'll get to know in the guidelines. If the facility is PCI enabled, you do your primary PCI. If not, more than 120 minutes, you thrombolize if no contraindication and refer to a facility. If the facility is within 120 minutes, you do not thrombolize, you send for the primary PCI. If the person is very high risk non-ST elevation ACS based on the risk stratification earlier we mentioned, then you treat the patient just like someone who has had a STEMI. If the patient is high risk, then it means that the patient has to have the coronary angiography with possible PCI within 24 hours. And remember that as part of management, they have to receive dual antiplatelet therapy, which is mainly aspirin with a P2Y12 inhibitor. With a P2Y12 inhibitors, you are looking at in order of potency for antithrombotic effect, you are looking at prasugrel, ticagrelor, and clopidogrel. And in that same order, risk of bleeding, prasugrel is high, followed by ticagrelor, then the lowest risk of bleeding is clopidogrel. In addition to anticoagulation during the period of the ACS, or acute coronary syndrome, the options unfractionated heparin, low molecular weight heparin, bivalirudin, and fandopirinose. And there are indications to use preference for some of these, which we'll get to know in the subsequent presentations. And so, essentially, this is what ACS is about. And don't forget your secondary prevention when you're managing patients. You're looking at both pharmacological and non-pharmacological. So statins are part of the management, smoking cessation, risk factor modification, psychosocial consult, cardiac rehabilitation. And if you stent, the duration of dual antiplatelet therapy based on your thrombotic and your bleeding risk, which will be discussed subsequently. What will be the duration of dual antiplatelet therapy? What is the duration of single or monotherapy antiplatelets? What will inform dual? What will inform mono? When do you stop it? Is it 3 months, 6 months, or 12 months? So now we go into the guidelines. Now, the new recommendations that were added are as follows. So if patient presenting with acute coronary syndrome, if patient presenting acute coronary syndrome, you stop the dual antiplatelet therapy to undergo a coronary bypass graft. It is recommended that they resume the dual antiplatelet therapy after surgery for at least 2 months. So a patient has come with acute coronary syndrome, but the treatment is not amenable to primary PCI. So you opted for bypass. Cabbage we all know that for bypass, you have to stop the ducts to be able to go ahead and do the bypass surgery. But post-bypass, the recommendation is to resume the dual antiplatelet therapy for at least 2 months, and that is class 1. Now, in older patients, if based on the risk of bleeding, if they have high bleeding risk, then like I said, clopidogrel has a lower risk of bleeding compared to ticagrelor and prasugrel. And so you may consider clopidogrel as the P2Y12 agent instead of ticagrelor or prasugrel. And the recommendation is 2V. Now, in terms of alternative antithrombotic therapy regimens, what are the recommendations? If your patient is event-free after 3 to 6 months on your dual antiplatelet therapy, and they are not at high ischemic risk, then a single antiplatelet therapy, preferably with a P2Y12 receptor inhibitor, should be considered, and that's a class 2A. So like I said, most recommendations previously was 12 months of dual antiplatelet therapy, unless there are contraindications with minimum of 6 months. Now, if your patient has not had any events or any complications within that 3 to 6 months of being on dual antiplatelet therapy, and if you assess the risk of thrombosis or the ischemic risk and it's not high, then you can put the patient on a single antiplatelet therapy, which in this case, P2Y12 inhibitors are what is being recommended, as against continuing with only aspirin rather. So P2Y12, that's a 2A recommendation. And P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin monotherapy for long-term treatment, which is 2B. So usually after the DAPT therapy, you leave the patient on a single antiplatelet therapy. Most used to do only aspirin for the long term, but now the recommendation is you can replace aspirin with a P2Y12 inhibitor as a monotherapy, and that is 2B. In high bleeding risk patients, aspirin or P2Y12 receptor monotherapy after 1 month of DAPT may be considered. So essentially the same principle. If the bleeding risk is high, then after a month, you may consider stopping the dual antiplatelets to do a single or monotherapy after a month. That's 2B. In patients requiring oral anticoagulants, withdrawing antiplatelet therapy at 6 months, whilst continuing oral anticoagulation alone may be considered. And this one essentially is still based on bleeding risk, balancing it with your ischemic risk. Because by 6 months, ideally, if the ischemic risk or is not high, then the DAP therapy should have at least achieved its purpose. And so you can continue with the oral anticoagulation therapy as indicated. For example, patient has AF or has another indication requiring long-term anticoagulation. De-escalation of antiplatelet therapy in the first 30 days after ACS event is not recommended. So that is class 3. Now, with respect to cardiac arrest, evaluation of neurological prognosis no earlier than 72 hours after admission is recommended in all comatose survivors after cardiac arrest. This is already part of the cardiac arrest ACLS protocol. Now, transport of patients with out-of-hospital cardiac arrest to cardiac arrest center according to local protocol should be considered. So yes, ideally, there are centers that you know can improve outcomes. So those are the centers that you should send your patients. Unfortunately, I don't think we have such centers readily available in the African or sub-Saharan part of the continent. With respect to the technical aspects of invasive strategies, in patients with spontaneous coronary artery dissection, PCI is recommended only for patients with symptoms and signs of ongoing myocardial ischemia, a large area of myocardium in jeopardy, and reduced antegrade flow. So that's a class 1 recommendation. Mostly, SCAD is managed conservatively, and it's quite common in pregnant women. And the only indications for PCI, because of the technical challenges when it comes to PCI in SCAD, is as stated when there is ongoing myocardial ischemia or there's a risk of large area of myocardium to be damaged. Now, intravascular ultrasound imaging IVOS should be considered to guide PCI. It's a 2A, and this is not really available in several facilities in the continent. Intravascular imaging, preferably OCT, may be considered in patients with ambiguous corporate lesions. So lesions that you are not certain are the corporate vessels, because in acute STEMI, we know, or the recommendation is to deal with the corporate vessel and come out as soon as possible. Though there has been studies to show that non-corporate vessels can still be stented within 45 days post the initial corporate vessels being stented. However, the teaching is always to go for the corporate vessels. But so in situations where you can't tell with certainty which the corporate vessel is, then you can rely on some of this advanced imaging to help guide decision making so that you can know which vessel to revascularize. Stage PCI of the non-infarct related artery should be considered, which is a 2A, based on the studies that were done, especially in patients presenting with cardiogenic shock. Now, recommendations for multivessel disease in hemodynamically stable STEMI patients undergoing primary PCI. So it is recommended that PCI of the non-infarct related artery is based on angiographic severity, which is obvious that if you are going to stent a patient and the infarct related artery or the corporate vessel, you are done with that and you want to stent a non-corporate vessel, obviously you should look at the significance of that non-corporate vessel to stent, and not just stent because you've seen an obstructive disease of at least 50%. Invasive epidural functional assessment of non-corporate segments of the infarct-related artery is not recommended during the index procedure. Like I said, the index procedure is mostly to deal with the infarct-related artery or the corporate artery, and not to go and explore and cause more complications. Recommendations for acute coronary syndrome complications. Implantation of a permanent pacemaker is recommended when high degree AV block does not resolve within a waiting period of at least 5 days after MI. This is self-explanatory. And for cardiac MRI, you should consider it in patients with equivocal echocardiogram images or in cases of high clinical suspicion of LV thrombus. It's a 2A recommendation because we know the limitations of transthoracic echocardiogram, especially when it comes to visualizing the apex of the LV. And so even in the absence of apical thrombus, it may be challenging to see the apex clearly unless in patients with very good echocardiographic windows. So in the sense where we think there's high risk of apical thrombus or LV thrombus, and the cardiac MRI is a good option. Following acute myocardial infarction, contrast echocardiogram may be considered for detection of the LV thrombus if the apex is not visualized. So similar to that of the cardiac MRI. However, the cardiac MRI is placed above that of the contrast echo. Contrast echo is 2B. In patients with high degree AV block, in the context of anterior wall MI and acute heart failure, early device implantation may be considered. So CRT ID or CRTP, maybe that's a 2B. In patients with recurrent life-threatening ventricular arrhythmias, sedation or general anesthesia to reduce sympathetic drive may be considered. That is also a 2B recommendation. I think one of our colleagues probably is marking the screen. I don't know if the colleague can probably stop that. So in respect to acute coronary syndrome with comorbid conditions, it is recommended to base the choice of long-term glucose-lowering treatment on the presence of comorbidities, including heart failure, CKD, and obesity. I think this has been emphasized in the new guidelines when it comes to the management of diabetes or glucose-lowering therapy. For frail older patients with comorbidities, a holistic approach is recommended to individualize interventional and pharmacological treatment after careful evaluation of the risks and benefits. +1 recommendation. An invasive strategy is recommended in cancer patients presenting with high-risk ACS with expected survival of greater than or equal to 6 months. So the idea here is if the life expectancy is lower than 6 months, then your invasive approach may not offer the best of outcome in terms of benefit against risk and cost. So that should inform the decision. A temporary interruption of cancer therapy is recommended in patients in whom the cancer therapy is suspected to be contributing to the cause of the ACS. That's also +1. A conservative non-invasive strategy should be considered in ACS patients with poor cancer prognosis, and this is a 2A. And aspirin is not recommended in patients with platelet count of less than 10,000 per microliter. And clopidogrel is not recommended in cancer patients with platelet count less than 30,000 per microliter. In ACS patients with cancer and platelet less than 50,000, prasugrel or ticagrelor is not recommended. Now, for long-term management, high-intensity lipid-lowering therapy from the index ACS hospitalization is recommended. That's +1. And low-dose colchicine may be considered, particularly if other risk factors are insufficiently controlled or if recurrent cardiovascular disease events occur under optimal therapy. That's a 2B. And combination therapy with high-dose statin plus ezetimibe may be considered on the index hospitalization. That's a 2B. You may have a patient who is having LDL of probably 5, and you know that you are unlikely or LDL of 6 to achieve the 50% reduction in 3 months. You may combine it with ezetimibe ab initio to help achieve that target of less than 50% in 4 to 12 weeks. Recommendations for patient perspective in acute coronary syndrome care. So patient-centered care is recommended by assessing and adhering to individual patient preferences, needs, and beliefs, and ensuring that patient values are used to inform all clinical decisions. That's class one. It is recommended to include ACS patients in decision making as much as their condition allows, and to inform them about the risk of adverse events, radiation exposure, and alternative options. Decision aids should be used to facilitate the discussion. Plus one, it is recommended to assess symptoms using methods that help patients to describe their experience. So essentially, the first three are suggesting things that ideally should be done routinely. Use of the teach back technique for decision support during the securing of informed consent should be considered. So basically what you do is after explaining something to the patient, you want the patient to also now explain back to you for you to understand. And that reinforces the communication to the patient. Patient discharge information should be provided in both written and verbal formats prior to discharge. Adequate preparation and education for patient discharge should, using the teach back technique and or motivational interview, giving information in chunks and checking for understanding should be considered. Assessment of mental well-being using a validated tool and onward psychological referral when appropriate should be considered. So all this is part of the cardiac rehabilitation because that also involves psychosocial evaluation. Now, so those were the new recommendations that were added. Where were the recommendations that were revised from the 2017-2020 versions? So in the old guidelines, with respect to suspected non-ST elevation acute coronary syndrome, in patients with no recurrence of chest pain, normal ECG findings, and normal levels of cardiac troponins. And in that sense, we are looking at high sensitivity, but still with suspected ACS and non-invasive stress tests, preferably with imaging for inducible ischemia or coronary tomography scan is recommended before deciding on an invasive approach. So that was a class one recommendation. So you have a patient that had ACS, you've evaluated, but you don't have evidence by definition to support a diagnosis of ACS, but you still feel that this patient has ACS. Then you could have done a CT coronary angiogram or a stress echocardiogram or a stress SPECT or stress PET. It was a class one, but now it's been the level of recommendation has reduced to 2A in patients with suspected ACS with non-elevated or uncertain cardiac troponins, no ECG changes, and no recurrence of pain. Incorporating the coronary angiogram, CT coronary angiogram, or non-invasive stress imaging as part of the initial workup has been reduced to 2A. Now, with respect to the timing of invasive strategy in non-ST elevation ACS, the old guidelines said an early invasive strategy within 24 hours is recommended in patients with any of the following high-risk criteria. Diagnosis of NSTEMI suggested by the diagnostic algorithm we went through, dynamic or presumably new contiguous STT segment changes suggesting ongoing ischemia, transient ST elevation, or grade score greater than 40. So for this, the level of evidence recommendation was 1. Now, the level of evidence has not changed, but the recommendation has been down regulated to 2A, that an early invasive strategy within 25 should be considered in patients with at least one of the following: confirmed diagnosis of non-STEMI based on the algorithms, dynamic ST changes or T-wave changes, transient ST elevation, and grade score greater than 140. So it's still recommended, but the level or the strength of recommendation has moved to 2A. Recommendations for antiplatelets and anticoagulation therapy in STEMI. So the old guidelines said a potent P2Y12 inhibitor prasugrel or ticagrelor or clopidogrel, if they are not available or contraindicated, is recommended before or at latest at the time of PCI and maintained over 12 months unless there are contraindications such as excessive bleeding. Now, pre-treatment with P2Y12 inhibitor may be considered in patients undergoing primary PCI. That is a 2B from the 1. With respect to long-term antithrombotic therapy, the old guidelines, so I'll be doing the old guidelines first, then I'll do the current update. So after stent implantation in patients undergoing a strategy of dual antiplatelet therapy, stopping aspirin after 3 to 6 months should be considered depending on the balance between ischemic and bleeding risks. And in the current one, patients who are event-free after 3 to 6 months of DAPT who are not high risk, ischemic risk, single antiplatelet therapy should be considered. So it's similar, but it's just the wording that has been tweaked a bit. Recommendations for cardiac arrest and out of hospital cardiac arrest. So delayed as opposed to immediate angiography should be considered after hemodynamically stable patients without ST elevation successfully resuscitated after out of hospital cardiac arrest. Was a 3B. So if a patient had a cardiac arrest and in ROSC, you run an ECG and you saw ST changes, but not ST elevation, it was truly a recommendation to consider coronary angiography with possible PCI. However, now that is not recommended if there's no ST elevation. Coronary angiogram is not routine post cardiac arrest in the absence of the persistent ST elevation. Now, targeted temperature management aimed for a constant temperature between 32 to 36 for at least 24 hours is indicated in patients who remain unconscious post cardiac arrest. Then the current one is temperature control, i.e. continuous monitoring of core temperature and active prevention of fever, which was defined as greater than 37.7 is recommended after either out of hospital or in hospital cardiac arrest for adults who remain unresponsive. So it's the same principle, trying to halt neuronal injury as much as possible post cardiac arrest. In hospital management, when echocardiography is suboptimal or inconclusive, an alternative imaging method such as CMR should be considered. It was 2A, now it is 2B. With multivessel disease in hemodynamically stable STEMI patients undergoing PCI, routine revascularization of the non-infarct related artery lesions should be considered in STEMI patients with multivessel disease before it was a 2A. But now, based on the current researches that have been done, it's been moved up to a class 1 recommendation for you to be able to revascularize in the non-corporate or the non-infarct related artery within 45 days post the index PCI. Recommendations for acute coronary syndrome comorbid conditions. So glucose-lowering therapy should be considered in ACS patients with blood glucose greater than 10 millimole per liter with the target adapted to comorbidities, whilst episodes of hypoglycemia should be avoided. 2A, and glucose-lowering therapy should be considered in patients with ACS with persistent hyperglycemia while episodes. So the old guideline was specific with the glucose cutoff, essentially saying greater than 10, but the new one was not categorical or specific with the glucose cutoff. Now, so we've looked at the new ones, we've looked at the ones they reviewed. Now, in terms of the guideline in total, so when it comes to the history and the diagnosis with acute coronary syndrome, it is recommended to base the diagnosis and initial short-term risk stratification of ACS on combined clinical history, symptoms, vital signs, and other physical findings. So essentially, It's what we do routinely that has been put together and it's been reinforced to and also being recommended that when you see a patient, the decision should be made after a thorough evaluation of the patient from history, physical examination, investigations. Now, an ECG, 12-lead ECG is recommended as soon as possible at the point of first medical contact in less than 10 minutes. I believe this is not what happens in most facilities, but that is the recommendation. Continuous ECG monitoring and the availability of a defibrillator capacity is recommended as soon as possible in all patients with suspected STEMI or in suspected ACS with other ECG changes or ongoing chest pain, and once the diagnosis of MI is made. Because we know they are at risk of cardiac arrest, so it's important for us to have the continuous monitoring. The use of additional ECG leads, right-sided and posterior leads, is recommended in case of inferior STEMI or in total vessel occlusion is suspected, and standard leads are inconclusive. An additional 12-lead ECG is recommended in cases with recurrent symptoms or diagnostic uncertainty. So patient comes, initial ECG is normal, and you still suspect that it may be an ACS. Repeat ECGs are recommended. With respect to the blood sampling, it is recommended to measure cardiac troponins with high sensitivity assays immediately after presentation and to obtain the results within 60 minutes of blood sampling. I think with the discussion, I want to hear comments from colleagues and seniors. With 60 minutes, it's in most centers in Ghana, it's not practical. So I don't know about Nigeria, but I think we can discuss that. It is recommended to use the ESC algorithm approach with serial HS high sensitive troponins, the 0-1 hour or the 0-2 hour algorithm, which still is a bit impractical and uncertain, considering that getting your initial troponins at time 0 even can take so much time. Additional testing after 3 hours is recommended if the first two high sensitive troponins measurements of 0-1 hour algorithm are inconclusive and no alternative diagnosis explaining the conditions have been made. Is a good recommendation, which we agree with, but in our environment, the turnover time for troponins won't make this practical. The use of established risk scores like the GRACE score, TIMI score, etc., for prognosis estimation should be considered. And triage for emergency reperfusion strategy. It is recommended that patients with suspected STEMI are immediately triaged for an emergency reperfusion strategy. So these are things that we do, but they are just reinforcing them and giving them recommendations. Now, with recommendations for non-invasive imaging as part of the initial evaluation of the patient with suspected ACS, emergency transthoracic echocardiogram is recommended in patients with suspected ACS presenting with cardiogenic shock or suspected mechanical complications. Class 1, in patients with suspected ACS, non-elevated or uncertain troponins, no ECG changes, and no recurrence of pain, incorporating coronary, CT coronary angiogram, or non-invasive stress test imaging as part of the initial workup should be considered, which is part of the ones we mentioned earlier as part of the review of the old guidelines. Emergency TTE should be considered at triage in cases of diagnostic uncertainty, but this should not result in delays in transfer to the cardiac catheterization laboratory if the suspicion of an acute coronary syndrome. If there is suspicion of an acute coronary artery occlusion. Routine early coronary and CT coronary angiogram in patients with suspected ACS is not recommended. With respect to the initial management, oxygen is indicated if SATs are less than 90%. That's class 1. So if the SAT is not less than 90% or there is no obvious signs of breathlessness or respiratory distress, oxygen is not indicated based on the AVOID trial. Routine oxygen is not recommended in patients without hypoxia. Now, opioids should be considered to relieve pain or a mild tranquilizer should be considered in patients who are anxious, both 2A. Intravenous beta blockers should be considered at the time of presentation in patients undergoing primary PCI with no signs of acute heart failure and systolic blood pressure greater than 120 and no other contraindication, which is 2A. There was a study that showed that for those with normal EF, the use of the beta blockers was not helpful or they didn't improve any change. So I think maybe the subsequent guidelines may move this probably to a 2B for those with preserved EF or may give it a 3. In terms of pre-hospital logistics, it is recommended that pre-hospital management of patients with a working diagnosis of STEMI is based on regional networks designed to deliver reperfusion therapy expeditiously and effectively without efforts made to make primary PCI available to as many patients. So for us, we are yet to have an established PCI network or STEMI network fully running in the country. So maybe our colleagues in Nigeria can comment on that during the questions, contributions time. It is recommended that primary PCI capable centers deliver a 24/7 service and are able to perform PCI without delay. Class 1. It is recommended that patients transferred from primary PCI bypass the emergency department and CCU or ICU and are transferred directly to the cath lab. It is recommended that EMS transfer patients with suspected STEMI to PCI-capable center, bypassing non-PCI centers. So all this is to reduce the delay, the systemic delay that results to loss of cardiac muscle, because time is muscle. It is recommended that ambulance teams are trained and equipped to identify ECG patterns suggestive of acute coronary occlusion and to administer initial therapy, including defibrillation and fibrinolysis when applicable. It is recommended that all hospitals and EMS participating in the care of patients with suspected STEMI record and audit delay times and work together to achieve and maintain targets. Now, respect to reperfusion therapy and timing of invasive strategies. Reperfusion therapy is recommended in all patients with a working diagnosis of STEMI and symptoms of ischemia less than or equal to 12 hours. So if it is less than or equal to 12 hours, it's straight, the indication is clear for STEMI. Primary PCI strategy is recommended over fibrinolysis if the anticipated time from diagnosis to PCI is less than 120 minutes. And that is what informs the decision that when the PCI capable facility is within 120 minutes from where you are, you do not thrombolize, but you offer a primary PCI by referring the patient to that center. If timely primary PCI cannot be performed in patients with a working diagnosis of STEMI, fibrinolytic therapy is recommended within 12 hours of onset. So this is where you can't do the PCI in your center, but the facility that can do PCI is more than 120 minutes away. So you offer fibrinolysis if not contraindicated, especially benefits within 12 hours from onset. After 12 hours, the benefit of the fibrinolysis is in question and it's not recommended. Rescue PCI is recommended for failed fibrinolysis. So when you have a patient who you can't offer primary PCI in your facility, and the facility that will offer the PCI was more than 24 hours, more than 120 minutes from you, you offered thrombolysis or fibrinolysis and you refer the patient. Now, when the patient gets to that facility that can do PCI, they will evaluate whether your thrombolysis was successful or not. And that is defined by a reduction in your ST segment elevation of 50% or more within 60 to 90 minutes. If it's not, then it means that your patient will require a rescue PCI. Or if there is also presence of hemodynamic or electrical instability, worsening ischemia, or persistent chest pain, then irrespective of whether your thrombolysis gave you a resolution of ST elevation of greater than 50% within 60 to 90 minutes, you still have to do a rescue PCI. So when you give thrombolysis, the PCI you do subsequently is not a primary PCI, it's a rescue PCI. Transfer to patients with to PCI capable center is recommended in all patients after fibrinolysis because you may lyse the clots and the clot may move to other relatively smaller vessels and still cause obstruction. Emergency angiography and PCI of infarct-related artery, if indicated, are recommended in patients with new onset or persistent heart failure or shock after fibrinolysis. Of course, it reinforces the earlier points. Angiography and PCI of the infarct-related artery, if indicated, is recommended between 2 to 24 hours after successful fibrinolysis. The reason for the 2 hours to 24 hours that within 2 hours is mostly considered for primary PCI. 2 to 24 hours falls within rescue PCI or early PCI. In patients with a working diagnosis of STEMI and a time from onset more than 12 hours, a primary PCI strategy is recommended in the presence of ongoing symptoms suggestive of ischemia, hemodynamic instability, or life-threatening arrhythmias. Preferably, you want to go in within 12 hours, but beyond 12 hours, if your patient has the evidence of ischemia, ongoing chest pain, BPs are low, VT, sustained VTs, etc., then even though it's beyond 12 hours, it's advised for you to go in. However, the routine PCI of an occluded vessel is not recommended in STEMI beyond 48 hours without persistent symptoms. The reason this was from the Oates trial. So if you have a patient who has come with STEMI beyond 48 hours without persistent symptoms, that patient should not have a routine PCI. A routine primary PCI should be considered in STEMI patient between 12 to 48 hours after onset. So what we have noticed in our center is that for those who usually come beyond 12 hours, or maybe specifically 24 to 48 hours, though the guidelines is a 2A, we seem not to get relative good outcomes for such patients, even though the recommendations gives you room to go in within 48 hours. Invasive strategy in non-ST elevation acute coronary syndrome. An invasive strategy is recommended whilst on admission if the patient has a high risk or high risk suspicion of unstable angina based on the risk factors we've defined earlier on. A selective invasive approach is recommended in patients with very high or high risk non-ST elevation acute coronary syndrome and with a low index of suspicion for that. An immediate invasive strategy is recommended in patients with a working diagnosis of non-ST elevation ACS and with one of the following very high risk, which we mentioned earlier: hemodynamic instability, recurrent or refractory chest pain despite medical therapy, life-threatening arrhythmias, mechanical complications, acute heart failure, recurrent dynamic ST changes. For such patients, you treat them like STEM, and you want to do immediate coronary angiogram with PCI if possible. Then early invasive strategy within 24 hours should be considered for patients with at least one of the following high risk: confirmed diagnosis of non-STEMI, dynamic ST changes, or T waves changes, then transient ST elevation, and a gray score greater than 140. So essentially, if the patient is very high risk, you treat the person as STEMI. If it is high risk, then you do early invasive, which is 2 to 24 hours. That's a 2A. Now, with respect to antiplatelet and anticoagulants, which is a very sometimes difficult to do based on the risk of bleeding and the ischemic risk. Aspirin is recommended for all patients without contraindications at an initial oral loading dose of 150 to 300 and maintenance dose of 75 to 100 for long-term therapy. In all ACS patients, P2Y12 receptor inhibitor is recommended in addition to aspirin, given as an initial loading dose, followed by medical maintenance dose for 12 months, unless there is high bleeding risk. A proton pump inhibitor is in combination with dual antiplatelet therapy is recommended in patients at high risk of gastrointestinal bleeding. Prasugrel is recommended in P2Y12 receptor inhibitor naive patients proceeding to PCI. The doses is dependent on the age and also the weight, so there are modifications as stated. Ticagrelor is recommended irrespective of the treatment strategy, either conservative or invasive. Clopidogrel with a loading dose of up to 600 milligram and maintenance dose of 75 is recommended when prasugrel or ticagrelor are not available or cannot be tolerated or are contraindicated. Clopidogrel is a prodrug. It has the lowest bleeding risk when compared to the others and the lowest antithrombotic benefit compared to the others. In patients presenting with ACS, stop dual antiplatelet therapy to undergo CABG. It is recommended they resume after the surgery for 12. So these are the new ones that were added that I mentioned earlier. Prasugrel should be considered in preference to ticagrelor for ACS patients who proceed to PCI. That's a 2A. And the GP2B3A receptor antagonist should be considered if there is evidence of no reflow or thrombotic complications. So they are usually used when there's complications as a rescue. They are not used routinely. In P2Y12 receptor inhibitor naive patients undergoing PCI, cangrelor may be considered, which is the IV intravenous form of a P2Y12 inhibitor. That's a 2B. In older ACS patients, especially if a high bleeding risk is present, clopidogrel as a P2Y12 receptor may be considered. Like we said, it has relatively the lowest bleeding risk compared to ticagrelor and prasugrel. Pre-treatment with P2Y12 receptor inhibitor may be considered in patients undergoing primary PCI. That's a 2B. Pre-treatment with P2Y12 receptor Sorry, I had a call. Pre-treatment with P2Y12 receptor inhibitors may be considered in non-STEMI who are not expected to undergo an early invasive strategy and do not have a high bleeding risk. That's a 2B. Pre-treatment with GP, glycoprotein 2B, 3A receptor antagonist is not recommended. As stated earlier, they are used for rescue when there's no reflow or you have complications. Routine pre-treatment with P2Y12 receptor inhibitor in non-ST elevation acute coronary syndrome patients in whom coronary anatomy is not known and early invasive management is planned is not recommended. Then anticoagulant therapy. Parenteral anticoagulation is recommended for all patients with ACS at the time of diagnosis. +1, routine use of unfractionated heparin, which is the weight-adjusted IV bolus during PCI, 70 to 100 units per kilo is recommended in patients undergoing PCI. Intravenous enoxaparin at the time of PCI should be considered in patients pre-treated with subcutaneous enoxaparin. I think this is from the ATOL study, ATOLL study, which compared enoxaparin with unfractionated heparin for PCI. Discontinuation of parenteral anticoagulation should be considered immediately after an invasive procedure. So this is a 2A. So immediately after PCI, anticoagulation can be stopped, which is a 2A. However, because it's a 2A, you may have situations where it will still be continued practically. In our center, I have one of my consultants who want to at least do 24 hours most of the time than just stopping it, even though the recommendation is 2A, so it means that it's not a +1. Patients with STEMI, in patients with STEMI, enoxaparin should be considered as an alternative to unfractionated heparin in patients with STEMI undergoing PCI. It's a 2A. Bevaluridine with full dose post-PCI infusion should be considered as an alternative to unfractionated heparin in patients with STEMI undergoing primary PCI. So I think this one was informed by the BRIGHT study. Then fondaparinux is not recommended in patients with STEMI undergoing primary PCI. So fondaparinux is not recommended. I think this is the OASIS 6 trial. Then for patients with non-ST elevation ACS, in whom early invasive angiography is not anticipated, fondaparinux is recommended. So for non-ST elevation, the fondaparinux has benefit, but for STEMI it does not. So we should remember that. For patients with non-ST elevation ACS in whom early invasive angiography is anticipated, enoxaparin should be considered as an alternative to unfractionated heparin. So I think the fondaparinux in the non-STEMI with benefits is probably OASIS 5, and the STEMI is OASIS 6. So we can OASIS OASIS. I may be wrong, but I think we can check it out. Combining antiplatelets and oral anticoagulation. This can also be a very challenging thing to do. And as the default strategy for patients with atrial fibrillation and CHA2DS greater than or equal to 1 in men and 2. Now, we all know that the update of the AF in 2024 removed the sex component. So it's CHA2DS. So they may update this one. After up to a week of triple antithrombotic therapy following the ACS event, dual antiplatelet therapy using NOAC at a recommended dose for stroke prevention and single oral antiplatelet, preferably clopidogrel for up to 12 months is recommended. So essentially, if someone has a stent, ACS, you've stented, then you have to do dual antiplatelet therapy, but there's another indication for anticoagulation, as AF or intracardiac thrombus, then you have to give the DAPT and also give your anticoagulant at the same time. But you have to balance this with the risk of bleeding. So if the risk of bleeding is mostly high or moderate, then the recommendation is to do 1 week of the 3. Then after that 1 week, you do the anticoagulant because you have a permanent indication for the anticoagulation being the AF. Then you have to now reduce your dual antiplatelet therapy to a NOAC with a single antiplatelet. But because the risk of bleeding is low with clopidogrel, the recommendation is to do preferably clopidogrel together with your NOAC, considering the risk of bleeding. During PCI, unfractionated heparin bolus is recommended in any of the following circumstances. If the patient is on a NOAC, or if INR is less than 2.5 in patients who have received vitamin K antagonists. Then in patients with an indication for oral anticoagulation with vitamin K antagonists in combination with aspirin or clopidogrel, careful regulation of the dose intensity of the vitamin K antagonist with a target of 2 to 2.5 and time in therapeutic range of greater than 70% should be considered. So typically we would have done 2 to 3 if you were doing the anticoagulation for the AF, but because of the risk of bleeding, you're looking at 2 to 2.5 if you are using a VKA, and that's a 2A. Then when rivaroxaban is used and concerns about high bleeding risk prevail over ischemic stroke, rivaroxaban 50 mg daily should be considered in preference to the 20 mg for the duration of concomitant single antiplatelet or dual antiplatelet therapy. So this is self-explanatory. In patients with high bleeding risk, dabigatran 110 BD should be considered in preference of the 150 mg BD for the duration of concomitant single antiplatelet or dual antiplatelet therapy to mitigate bleeding risk. In patients requiring anticoagulation and treated medically, a single antiplatelet agent in addition to the oral and should be considered for up to a year. That is 2A. In patients treated with oral anticoagulation, aspirin plus clopidogrel for longer than 1 week and up to 1 month should be considered in those with high ischemic risk or with other anatomical or procedural character that are judged to outweigh the bleeding risk. So earlier on, we do triple therapy for 1 week only, provided the ischemic risk is acceptable. That was one recommendation, class 1. But if the ischemic risk is very high, based on factors that could be the number of stents, anatomical, etc., then you may have to do the triple therapy up to a month to reduce your ischemic risk and minimize the risk of recurrence or stent thrombosis as a complication. But it's a 2A compared to the triple therapy for 1 week, which is a class 1. In patients requiring oral anticoagulants, withdrawing antiplatelet therapy at 6 months whilst continuing oral anticoagulants may be considered. So this can be just opposed the recommendation where 3 to 6 months of dual antiplatelet therapy is being recommended for patients who have not had any events within that 3 to 6 months period. So in that sense, you can easily do only the oral anticoagulants only after 6 months, provided the patient had no risk, has low ischemic risk, and had no events within that 3 to 6 months. Because the studies that inform these recommendations usually were controlled and used quite advanced stent types compared to the usual routine stents we use. So you have to look out at your bleeding risk and balance it well against your ischemic risk. In terms of the alternative antithrombotic therapy regimens, so in patients who are event-free for 3 to 6 months on the DAPT or who are not at high ischemic risk, single antiplatelet therapy should be considered. This is what we mentioned earlier on. De-escalation of P2Y12 receptor inhibitor, as in switching from a high antithrombotic agent such as prasugrel, ticagrelor to clopidogrel, may be considered as an alternative to minimize the bleeding risk. In high bleeding risk patients, aspirin or P2Y12 receptor inhibitor monotherapy after 1 month may be considered in those with very high bleeding risk. De-escalation of antiplatelet therapy in the first 30 days after ACS event is not recommended. So if you start prasugrel or ticagrelor, it's recommended that at least the first 30 days, you leave them on it before you de-escalate. In terms of prolonging antithrombotic therapy, discontinuation of antiplatelet therapy in patients treated with oral anticoagulation is recommended after 12 months. So at least by 12 months, and they are on anticoagulants, you can stop the antiplatelet therapy and do only the anticoagulation. That's a class 1. Adding a second antithrombotic agent to aspirin for extended long-term secondary prevention should be considered in patients with high ischemic risk without high bleeding risk. So after 12 months, you still want to continue your aspirin with clopidogrel or aspirin with another antithrombotic agent. It should be based on your ischemic risk and should be considered in those with very high ischemic risk. That's a 2A. Adding a second antithrombotic agent to aspirin for extended long-term secondary prevention may be considered in patients with moderate ischemic risk and without high bleeding risk. That's a 2B. And P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin monotherapy for long-term treatment. This is 2B. But with time, it appears this recommendation may move up from 2B to 2A. There seems to be a push for P2Y12 monotherapy compared to aspirin monotherapy for at least the 3 months to 6 months of the dual antiplatelet therapy. Recommendations for fibrinolytic therapy. When fibrinolysis is the perfusion strategy, it is recommended to initiate this treatment as soon as possible after diagnosis in the pre-hospital setting. And you should aim at less than 10 minutes to release the agents. We don't have situations where are paramedics thrombolized on site? I'm yet to hear of anything of such. A fibrin-specific agent, tenecteplase or alteplase, is recommended. In Ghana, tenecteplase is easily available, but it's quite expensive. So mostly if we are going to thrombolize, the likely option is tenecteplase. And because the single dose covers all the weights that you expect, viable weights for patients, that one appears to be a relatively affordable option. A half dose of tenecteplase should be considered in patients greater than 75 years of age. Now, antiplatelet co-therapy with fibrinolysis, aspirin and clopidogrel are recommended. So you're not going to stop because you are going to thrombolize your patients. Anticoagulation is recommended in patients treated with fibrinolysis until revascularization is performed or for a duration of hospital stay up to 8 days. Enoxaparin IV followed by subcut is recommended as the preferred anticoagulant in cases of fibrinolysis. When enoxaparin is not available, unfractionated heparin is recommended as a weight-adjusted IV bolus followed by infusion. In patients treated with streptokinase, an IV bolus of fandoparinus followed by a subcut dose 24 hours later should be considered. That is a 2B. Now, with respect to cardiac arrest, I think we've mentioned this earlier on, so I'll skip this. For cardiogenic shock, yes. So immediate coronary angiography and PCI of the infarct-related artery is recommended in patients with cardiogenic shock complicating ACS. Like we mentioned earlier, this is different. This is higher in terms of level of recommendation compared to the other ones where we spoke about the non-infarct-related artery within 45 days. Emergency coverage is recommended for ACS-related cardiogenic shock if PCI of the infarct-related artery is not feasible or unsuccessful. In cases of hemodynamic instability, emergency surgical or catheter-based repair of mechanical complications of ACS is recommended based on heart team discussion. Fibrinolysis should be considered in STEMI patients presenting with cardiogenic shock if a primary PCI strategy is not available within 120 minutes from the time of STEMI diagnosis and mechanical complications have been ruled out. That is 2A. In patients with ACS and severe refractory cardiogenic shock, short-term mechanical circulatory support may be considered. The routine use of intra-aortic balloon pump in acute coronary syndrome patients with cardiogenic shock and without mechanical complications is not recommended. So the catch here is there should be mechanical complications for you to consider supporting them with the intra-aortic balloon pump. The routine use here in patients with cardiogenic shock without mechanical complication not recommended. Now, with respect to in-hospital, I think we spoke about some of these. Of course, the patients who are high risk should be in ICU or the coronary care units. So patients with heart failure, arrhythmias, etc. High risk patients with STEMI or high risk non-STEMI should have monitoring for 24 hours. Then it is recommended that high-risk patients with successful perfusion therapy and an uncomplicated clinical course are kept in the CCU or ICU for a minimum of 24 hours where possible, after which they may be moved to a step-down monitored bed for additional 24 to 48 hours. Discharge of selected high-risk patients within 48 to 72 hours should be considered if early rehabilitation and adequate follow-up are arranged. Same-day transfer is selected in selected stable patients after successful and uninventable PCI should be considered. That is 2A. In terms of imaging, routine echo is recommended during hospitalization to assess regional or global LV function, detect mechanical complications, and exclude LV thrombus. When echocardiography is suboptimal or inconclusive, cardiac MRI may be considered as a 2B. Drug-eluting stents are recommended in preference to bare metal stents in all cases, class 1. In patients with spontaneous coronary artery dissection, PCI is recommended only for patients with symptoms and signs of ongoing myocardial ischemia, large area of myocardium in jeopardy, and reduced antegrade flow. Intravascular imaging should be considered to guide PCI. CABG should be considered in patients with an occluded infarct-related artery when PCI is not feasible or unsuccessful and there's large area of myocardium in jeopardy, that is 2A. Then intravascular imaging, preferably OCT, may be considered in patients with ambiguous culprit lesions, which we mentioned earlier, and the routine use of thrombus aspiration is not recommended. It's a class 3. Then with respect to the technical aspects, the radial access is recommended unless there are overriding procedural considerations. PCI with stent deployment in the infarct-related artery during the index procedure is recommended in patients undergoing PCI. Now, with respect to multivessel disease, revascularization strategy on patients should be based on the patient's clinical status and comorbidities, as well as the disease complexity, according to the principles of management of myocardial revascularization. So if you have a patient with multi-disease with ACS presenting a cardiogenic shock, the infarct-related artery-only PCI during the index procedure is recommended. Then the stage PCI of the non-infarct-related artery should be considered. That is 2A. If the person is hemodynamically stable with a STEMI and has multivessel disease, then complete revascularization is recommended during the index PCI procedure or within 45 days, which is from the complete trial. So for patients who are stable, you can do the non-infarct related the index or within 45 days. Whereas for cardiogenic shock, we deal with the index, the infarct-related artery, and the stage PCI of the non-infarct-related is recommended to be done later. It is recommended that PCI of the non-infarct-related artery is based on the angiographic severity. So the fact that patient is stable does not mean that the non-infarct-related artery is 50%, 56%, and though it's obstructive, it's above 50%, there's no clinical relevance of revascularizing that artery. We should not revascularize that territory. Invasive epicardial functional assessment of non-corporate segments of the infarct-related artery is not recommended in the index procedure. So multivessel disease in hemodynamically stable non-ST elevation ACS patients undergoing PCI. So we know that for patients with non-ST elevation going for PCI, they may be very high risk. So they will be going for the PCI within 2 hours of arrival, or if they are high risk, 2 hours to 24 hours, which is the early invasive approach. In patients presenting with non-ST elevation ACS and multivessel disease, complete revascularization should be considered preferably during the index procedure. So essentially, the concept is if the patient's risk during the procedure is relatively acceptable, moderate to low, then you can go ahead to stent the non-infarct related arteries, which are significant angiographical and hemodynamic, not just because they are obstructive more than 50%. Functional invasive evaluation of non-infarct related severity, artery severity during the index procedure may be considered. So functional invasive assessments are available, the FFR and other modalities. Now, recommendations for myocardial infarction with non-obstructive coronary arteries, MINOCA. So in patients who have a working diagnosis of MINOCA, cardiac MRI is recommended after invasive angiography. if the final diagnosis is not clear. So Minoka is a patient who has fulfilled the fourth universal definition of myocardial infarction, i.e., there is evidence of myocardial injury as defined as troponins above 99th centile of the upper limit range and has one of the following: ST elevation or ECG changes consistent with ischemia, history suggests of ischemia, regional wall motion abnormality by imaging consistent with the coronary artery territory, and you are certain, so if the person has fulfilled the diagnosis. However, you go and do diagnostic coronary angiography and there is no evidence of obstructive coronary artery disease to explain that this patient had a type 1 myocardial infarction, then you may look for other causes. So it's myocardial infarction by fourth universal definition, but there's no evidence of obstruction. So myocardial infarction, non-obstructive coronary arteries. So cardiac MRI has been recommended. Management of Minoka according to the final established underlying diagnosis is recommended, consistent with the appropriate disease-specific guidelines. So by the time you finish the evaluation, it may turn out the patient had a Takotsubo, or probably was even a myocarditis, or it was a microvascular obstruction, etc. In all patients with an initial working diagnosis of Minoka, it is recommended to follow a diagnostic algorithm to determine the underlying final diagnosis. Now, with respect to recommendations for acute coronary syndrome complications, so mechanical complications or non-mechanical complications. So for those with heart failure, intra-aortic balloon pump should be considered in patients with hemodynamic instability or cardiogenic shock due to ACS-related mechanical complications. So once again, the mechanical complications is what appears to be the emphasis when it comes to the use of intra-aortic balloon pump. For those with LV thrombus, cardiac MRI imaging should be considered in patients with equivocal echocardiographic images or in cases of high clinical suspicion of LV thrombus, which is the 2A. Oral anticoagulant therapy should be considered 3 to 6 months in patients with confirmed LV thrombus. I think this came up recently when we were discussing, and one of the colleagues mentioned it, that the recommendation is 3 to 6 months. So this is to reinforce that 3 to 6 months for LV thrombus post-MI, and there is no choice between VKA or NWAC. It is a 2A. Following an acute myocardial infarction, anterior MI, a contrast echocardiography may be considered for the detection of LV thrombus if the apex is not well defined. So that's 2B. So the cardiac MRI is superior in terms of the level of recommendations to contrast echo for the LV thrombus. With respect to atrial fibrillation, intravenous beta blockers are recommended when rate control is needed in the absence of acute heart failure or hypotension. Intravenous amiodarone is recommended when control is needed, when rate control is needed in the presence of acute heart failure and no hypotension. Immediate electrical cardioversion is recommended in patients with ACS and hemodynamic instability, and when adequate rate control cannot be achieved promptly with pharmacological agents. Intravenous amiodarone is recommended to facilitate electrical cardioversion and or decrease risk of early recurrence of AF after electrical cardioversion in unstable patients with recent onset AF. In patients with documented de novo AF during the acute phase of ACS, long-term oral anticoagulation should be considered depending on the CHADVA or CHADVAS now, but currently CHADVA, after taking the Hasbest score and the need for concomitant antiplatelet therapy into consideration. NWACs are preferred over the VKs. Now, with respect to ventricular arrhythmias, ICD is recommended to reduce sudden cardiac death in patients with symptomatic heart failure, class 2 to 3, and EF less than or equal to 35%, despite optimal medical therapy for 3 months and at least 6 weeks after MI, who are expected to survive for at least 1 year with good functional state. So this was mentioned yesterday by our colleague, Dr. Kumia, when it came to the device therapy in heart failure. So we should take note the cutoff EF is less than or equal to 35%, symptomatic HF plus New York Heart Association class 2, 3, and they should have been on optimal medical therapy for at least 3 months and at least 6 weeks after the MI. Within 48 hours of the MI is not an indication to put in an ICU if the patient gets an arrhythmia. Intravenous beta blocker and or amiodarone treatment is recommended for patients with polymorphic VT and or VF unless contraindicated. Prompt and complete revascularization is recommended to treat myocardial ischemia that may be present in patients with recurrent VT and or VF. The reason is that the VTs and VF may be a manifestation of the severe coronary artery disease. Transvenous catheter pacing, termination, and or overdrive pacing should be considered if VT cannot be controlled with repeated electrical cardioversion. 2A. Radiofrequency ablation at a specialized ablation center followed by ICD implantation should be considered in patients with recurrent VT or VF or electrical storm despite complete revascularization and optimal medical therapy. 2A. Treatment of recurrent VT with hemodynamic relevance despite repeated electrical cardioversion with lidocaine may be considered. Despite repeated electrical cardioversion with lidocaine may be considered if beta blockers, amiodarone, and overdrive stimulation are not effective. So lidocaine could be used as a backup if these options are not working. 2B. In patients with recurrent life-threatening ventricular arrhythmia, sedation or general anesthesia, to reduce sympathetic drive is considered. ICD implantation or the temporary use of a wearable cardioverter defibrillator may be considered less than 40 days after MI in selected patients who had incomplete revascularization, pre-existing LVEF dysfunction, occurrence of arrhythmias after 48 hours after STEMI onset polymorphic VT. So for the ICD, it has to be after 40 days or the 6 weeks. So greater than 48 hours is when you should consider a device or a defibrillator. However, if it's within 6 weeks, you may consider the wearable cardioverter because the permanent ICD implantation is after 6 weeks. So that is why that is true. Treatment of asymptomatic and hemodynamically irrelevant ventricular arrhythmias with antiarrhythmic drugs is not recommended for obvious reason that these antiarrhythmic drugs may be pro-arrhythmic themselves. So if they are not hemodynamically relevant or patient is asymptomatic, we do not go increasing the patient's risk of having another arrhythmia. For Brady's, in cases of sinus bradycardia with hemodynamic intolerance or high degree AV block without a stable escape rhythm, IV positive chronotropic medication, adrenaline vasopressin and or atropine is recommended. Temporary pacing is recommended in cases of failure to respond to atropine, and agent angiography with a view to revascularize is recommended in patients if the patient has not recovered previous reperfusion therapy. Implantation of a permanent pacemaker is recommended when high degree AV block does not resolve within the waiting period of at least 5 days. I think this was mentioned earlier. In selected patients with high degree AV block in the context of anterior wall MI and acute heart failure, early device implantation, CRT-D or CRT-P may be considered. It's a 2B. Pacing is not recommended if high degree AV block resolves after revascularization or spontaneously. Then recommendations for acute coronary syndrome in comorbid combinations. So this one, in CKD, you want to minimize the risk of contrast nephropathy. So the use of low or iso or smaller contrast media is recommended. It is recommended to assess your kidney function using GFR in all patients with ACS. It's recommended to apply the same diagnostic and therapeutic strategies in patients with CKD as in patients with normal kidney function. Hydration during and after angiography should be considered in patients at risk of contrast-induced nephropathy, especially in patients with acute kidney injury and or CKD with eGFR less than 30. Now, for patients with diabetes, it's recommended to base the choice of long-term glucose-lowering therapy treatment on the presence of comorbidities, including heart failure, CKD, and obesity. It is recommended to assess glycemic status at initial evaluation of ACS. It is recommended to frequently monitor blood glucose levels in patients with known diabetes mellitus or hyperglycemia. Then glucose-lowering therapy should be considered in patients with ACS with persistent hyperglycemia, while episodes of hypoglycemia should be avoided. So this was mentioned as part of the ones that were reviewed compared to the earlier guideline, which specified greater than 10. In older adults, it's recommended to apply the same diagnostic and treatment strategies in older patients as in young patients. It is recommended to adapt the choice and dosage of antithrombotic agents as well as secondary preventive medications to renal function, comorbidities, frailty, cognitive function, and specific contraindications. Then for frail older patients with comorbidities, a holistic approach is recommended to individualize interventional and pharmacological treatments after careful evaluation of the risks and benefits. Then for patients with cancers, we mentioned that if the life expectancy is less than 6 months, invasive strategy is not recommended. So this is what is re-emphasizing it. We've mentioned all the cutoffs for the antiplatelets already. With respect to cardiac rehabilitation, it is recommended for all patients to participate in a medically supervised, structured, and comprehensive multidisciplinary exercise-based cardiac rehabilitation and prevention program. There should be lifestyle management, which is part of the secondary prevention. So stopping smoking, healthy diet, alcohol restriction, aerobic physical activity, resistance exercise, and reduce entry time. In smokers, offer follow-up support, nicotine replacement therapy, varenicline or bupropion individually or in combination should be considered. Essentially, get the patient the help they need to stop smoking as much as possible. Lipid-lowering therapy, it is recommended high-dose statin therapy is initiated and continued as early as possible. So high-dose or high-intensity statin is 40 to 80 milligram at over 20 to 40 rosuvastatin. It is recommended to aim to achieve LDL of less than 1.4 and to reduce LDL of greater than or equal to 50% from baseline because they already have an established atherosclerotic cardiovascular disease. So your cutoff is 1.4 compared to those with high risk, which will be 1.8 of LDL and moderate risk 2.6. If the LDL goal is not achieved despite maximum tolerated statins after 4 to 6 weeks, the addition of ezetimibe is recommended. Some guidelines have said 4 to 12 weeks. This one says 4 to 6 weeks. If they've not achieved the targets of at the maximum tolerable dose, you add on. If the LDL target is not achieved despite maximum dose of the statin and ezetimibe, after 4 to 6 weeks of this combination therapy, then you should consider the PCSK9 inhibitors. So there's the monoclonal antibody and there's the RNA. In Ghana, we have inclisiran now, but it's very expensive. It is recommended to intensify lipid-lowering therapy during the index hospital admission. For patients with recurrent and atherothrombotic events, recurrence within 2 years of first ACS episode while taking maximum tolerated statin-based therapy, the goal now moves to less than 1.0. That is 2B. Combination therapy with high-dose statin plus ezetimibe may be considered from the index hospitalization. With the use of beta blockers is recommended in ACS with those with reduced EF less than or equal to 40%. routine beta blockers for all ACS, regardless of EF, should be considered. That is 2A. But with the new that research that showed that for those with preserved EF, they didn't have benefit. This may change and they may localize it to mildly reduce or reduce EF. For
So
RAS,
Eugene,
hello.
yeah, hello, hi, sorry. Maybe begin to summarize your last point so that we can have some time to interact.
Okay, I think let me see. I'm done actually. That's the last slide.
It's about finishing. That's why I didn't bother to stop.
So in terms of the patient perspectives, I think these have all been discussed already, trying to get the patient involved and to explain things to the patient for the patient to appreciate, and using feedback, patient talking back to you to appreciate what is going on is recommended. Thank you.
Well, thank you so much, Dr. Eugene, for that excellent presentation. And also thank you for stepping in. We're supposed to take a different guideline today, and Eugene was on call. He made this presentation ready and coming from work to present. And I also noticed your voice and the stress on it. Thank you so much. Thank you. So we'll be taking comments, reactions, and questions in no particular order, but let's follow this pattern. Every other person you can put up your hand and then you would speak. Then afterward, we'll go to the fellows in the house. Then finally, we'll take Dr. Kweki and then Prof. Oladimeji. So especially for the exam candidates, please, the floor is open for you to ask your questions. If you don't want to speak, you can type it on the chat box and I'll read it out.
Just to also add to that, the reason for you making comments may not be because Eugene have not talked about those things, but saying it again the second time is a way of reinforcing what he has said. I can tell you that some of these things that he has talked about must have been, heard by every one of us once upon a time in our course of training. So asking question, making comment, being part of it, it's just an act of reinforcement. It helps to create synapses, and that's how memory and form concern any subject. So, and apart from that,
All right.
exam day you will talk. So please, thank you.
All right. Thank you so much, Dr. Kweki, for that counsel to those going for exam. So we only have many persons telling you thank you for the wonderful work, Dr. Eugene Buffy. For those going for exam, Dr. Charles Okori, let's have a comment from you, Dr. Ovunda. Let's have the two comments from those going for exam. Then we'll just proceed in case nobody has any question to ask. Dr. Charles. Oh, Dr. Charles is not on the call. Okay, let's go to Dr. Ovunda, please.
All right, thank you very much, Chief Okopi. Nothing much. It was a very beautiful presentation. That's all I would have to say. I think nothing much to add.
All right, that's very good. Thank you so much. So we'll take, if there are any fellows in the house, so that we can round up this stuff in the next few minutes. Any fellows in the house to give contributions to this? All right, we don't have anybody. So Dr. Kweki, let's have your contribution before we go. Okay, Dr. Ayodeji, you can go ahead, unmute and speak.
Yes, good evening, sir. Good evening, consultants. Dr. Eugene, thanks for the presentation. Now, please, I wanted to just clarify the safest proton pump inhibitors, because one of the recommendations is you should consider adding a proton pump inhibitor to patients that are taking dual antiplatelets. I don't know whether you come across which one is advisable when you want to give such a proton pump inhibitor. And you also talk about the fact that you must stop the dual antiplatelet before the coronary artery bypass surgery. For how many hours or how many days before the surgery will you consider stopping those dual antiplatelets? That's the second clarification. The third one is you talk about the treatment of diabetic in ACS. The drug of choice, is it oral or is it parenteral? What was the the current thing. I just want to clarify.
Okay.
Thank you.
All right. Thank you. So, with respect to the cabbage, responding in not necessarily the order of questions, if it's an acute coronary syndrome with a complication, it's acute. It's not an elective case where you have the luxury of stopping the medications for a while. For example, the aspirin, the inhibition of the cyclooxygenase is irreversible. So there are guidelines. People recommend you stop aspirin I'll have to cross check, but I know the minimum for aspirin, some will recommend a minimum of 1 week. Clopidogrel, I think also is about 72 hours or 96. I'm not certain. I have to look at the specifics, but there are particular day duration for elective cases. But for the mechanical complications, when there is that one, I didn't come across a particular duration in terms of days you have to stop before you go in to fix it, because it could be quite urgent and life-threatening. With respect to if I remember, you mentioned about the PPI.
Yes.
The PPI and the P2Y12 antiplatelet. So, for example, omeprazole can significantly reduce the effectiveness of clopidogrel in terms of its antiplatelet interaction with the clopidogrel because of the inhibition of the cytochrome P enzyme. So if you are going to use clopidogrel, then maybe you may opt for is the brand that is coming in mind, but the exact drug like Pirates. I've forgotten what is in Pirates. Pardon me, but Pirates.
Is it pantoprazole or what?
I'm not certain. It may be one of them, but
it's abeprazole.
Okay. So maybe something like that. The Pirates is recommended because that one lacks that interaction between omeprazole and clopidogrel. Then your other question, please. You asked another one.
The treatment of diabetic.
So the current one was not specific. The old guidelines basically even mentioned the cutoff of 10, but this one says we should use the guidelines. So if we are going by the guidelines, if the patient in the acute setting, usually the recommendation is to use insulin in the acute setting. And when they are stable and on discharge, obviously there's an established ASCVD. So you go for the SGLT2. So that is how I'll respond to that.
All right, thank you so much. We have an interventionist in the house and our prof. Hello, prof. I don't know if you want to respond on the stoppage of anticoagulant prior to primary PCI.
Okay. Well, great question. So, as you rightly said, if you go for elective bypass, then you have a period of 5 to 7 days to stop the dual antiplatelet. But it's an emergency situation. So you have a period of, so the surgeons try to buy a period of 32 to 36 hours at least. So it's more of the way the risk of the ongoing emergency to the risk of the bleeding. So what do they now do if they don't have a choice but to just go in? So that's where they get a lot of platelet concentrate after the procedure. So patient has to be bombarded with fresh frozen plasma, platelet concentrate, because they will need to monitor the bleeding until the bleeding stops. Usually an headache for them. So they want to buy, every surgeon wants to buy as much time as possible. But not by the time, then the antidote is platelet concentrates, fresh frozen plasma, and everything that would support, that will reduce the risk of bleeding. Hope that is clear, sir.
Yeah, it's clear. Thank you so much, Prof. Do we have any other comments or questions from anyone? Chinemeke, going for the exam. Do you have any comments? Chineme, are you there? All right, so let's go to Dr. Kweki. Do you have any comments before we call on Prof again and close the class?
So Let me start by saying thank you to Dr. Eugene for a brilliant presentation. I really enjoyed it because tend to talk about every area of ACS in terms of the guidelines, and that's quite insightful. I just don't want to repeat all the things that have been said, but just to make some few comments on some of the questions that have been raised, and then I can make one or two comments to ACS, generally speaking. So in my experience, in terms of the PPIs that we usually use while we practice over here, we still go with either omeprazole or lansoprazole. Those are the two options that we use. I can see that the guideline that was presented, probably the specific that were not mentioned. So these are some of the things that are center specific. But where I practice currently, we tend to favor lansoprazole, but omeprazole is also part of the local hospital guideline. Then part of my experience in preparing patients for surgery, we tend to stop ticagrelor about 5 days, like he said, 5 to 7 days before the surgery, or most of the time 5 days before the surgery. We don't even use clopidogrel like that, except if the bleeding risk of the patient is high, vis-a-vis patient have some bleeding risk factors, so we could move towards clopidogrel. But generally, the local hospital guidelines tend to favor use of aspirin with ticagrelor, and for that reason, we usually stop ticagrelor 5 days before the surgery. And as part of my experience, we really don't stop aspirin preparing patients for bypass surgery. Talking of elective surgery now, not emergency surgery. Because again, usually we just prepare the patient, refer to the cardiothoracic center, and they do the surgery. But I still, part of my experience, we just leave the aspirins, but probably the surgeon will stop within, because once we refer the patient for the bypass surgery, the surgery doesn't happen immediately anyway, so it will take some time for them to stop you, 1 or 2, 3 days.
Dr. Kweki,
So,
there's this interrupting sound at your background. I don't know if you can help us mute it. Or are you in the hospital?
I am not in the hospital, but
Okay.
part of my
All
work
right.
looking after children, so it's really a lot of things on the
All right.
background.
Okay.
Sorry for that. So that's that. So I love the fact that diagnosis, it's important in case of ACS. I remember that you asking a question whether we were able to do troponin within 60 minutes. I can tell you that all over the world it's difficult to get that within 60 minutes, but it's quite possible to get it done. But even here, where we see a patient like that, it doesn't come out within 1 hour because of the volume of patients. So it's quite a challenge. I don't think it's just Africa. Sometimes we have this impression that outside Africa, the care is perfect. You get everything perfect. I don't think it's true. This thing is being recorded, but try not to make it more specific. But sometimes you don't even get taken triple till after 5 hours, 6 hours because of the volume of patients. So sometimes the idea of 6 minutes doesn't happen in most centers, even in the best centers in the world. Not because they can't do it, but because they have volume of patients. Can I reduce your volume? So that's something, but we must understand that diagnosis is important. And if you look at what he presented, history is important. Cardiac symptoms is important. You need to take a very good history, the typical cardiac sounding chest pain. It's important for you to look at your troponin. It's important for you to look at your ECG. And with these three, you can define your patients. And once you define your patient, the next question you want to ask yourself, what do I do? Is it STEMI or non-STEMI? If it's STEMI, the pathway is different. And I'm happy he talked about the idea of being able to assess PCI within 2 hours. That really works. That really works. In fact, if you work in some certain hospital that are not primary PCI centers, you will never see any STEMI cases all your life. That is because the ambulance team, the paramedics, they are so trained, they are so good, such that they receive the call from the patient for whatever in the country, in the community, and they arrive at the house of the patient, and they record the ECG, and they found that this is STEMI. They know the PCI center, they take the patient straight, there's communication, there's talk with the hospital. The hospital is aware that they are coming, and they already know the distance it will take them between where they are to where the hospital is. And if you are driving on the road and you see an ambulance, it's not like other part of the world where everybody blows siren. No other person blows siren in some part of the world. And the moment you hear that ambulance noise, you have to park your car. They can blow one way, they can beat the traffic. So they are the only people who can beat the traffic. And you have to just park. Either you park off the road, just slow down for them to pass. Because they already know from studies, from audit, that within 2 hours they'll be there. And before they get there, they will pull a call through. The primary PCR center, the people on call, the nurses on call, the cath lab is prepared. The moment they are arriving, all the things described in the textbook will happen, such that the dot to needle, time to balloon and all that will be correctly defined. So some of these things are possible. So that's why you don't see some of this happening. And for people that are far away from the primary PCR center, usually the local hospital can give fibrinolytic therapy. And while they are doing that, there's an ongoing discussion with the primary PCR center. I've been in those scenarios where you are the most senior person in charge at that time. You have to keep talking. So you're not going to be talking with the primary PCR center if fibrinolytic has failed. You're going to be talking with them from the beginning, from the time that the patient arrived, from the time you are going to give. So there's a continuous discussion such that after the fibrinolytic therapy, you are transferring to the PCR center. So these things are well coordinated, well rehearsed, well simulated, such that they usually can meet up with the time. So that's really important. Then, so I talked about diagnosis, about the response, and it works. I can tell you it works because the system is well organized. So because the system is well organized,
Dr. Kweki, I don't know if you can summarize your speech so that we can take them.
So the system is well organized and things tend to happen very fast. So it's important for us to be able to recognize it. And once we recognize it, we can take a decision going forward. The other things I need to just say as a roundup is that there are different complications and comorbidities that happen with patients with ACS. And these are things we need to put also in perspective. I know that this discussion did not capture cath lab experience. That will be captured under guidelines on myocardial revascularization. Then we can talk about the process of revascularization. So once again, thank you, Dr. Eugene. It's a brilliant discussion, and congratulations for that presentation. Bye-bye.
Thank you so much, Dr. Kweki, for the experience from where you're practicing from. For the sake of security reasons, we may not name those places. Sorry, please, for taking so much time. We're supposed to stop by 8, but let's call on Prof for a covering remark and his experience.
Yeah, so thank you, Dr. Chief Kweki, for this presentation. I wanted to ask Dr. Eugene a peculiar question on one of the slides that talked about revascularization, putting something that when stemma of the impacted area is occluded for more than 48 hours, PCI is not needed. Do you remember that slide, sir?
Yes, the one that says 48 hours. Yeah. Okay.
So I want to know what you understand by that statement. Yeah, so you can see it here. No, not this one. No, not this one. Where you're talking about PCI for it's still in the early slides.
Okay, this one.
No. There's still a place. Continue.
Okay.
No. I remember that was after. Continue, sir. So that was after the place. Okay, now this place. Routine PCI of an occluded. You've passed it.
Okay. I think there's internet lag because I was on that page and you said no, so I moved. Okay, let me go back.
Yeah, it's that page.
Yeah.
It says routine PCI is in an occluded index code. Yes, that one. Routine PCI of an occluded index. Yeah, can you explain it? Yes.
So routine PCI of an occluded impact-related artery is not recommended in STEMI patients presenting greater than 48 hours after symptom onset and without persistent symptoms. So what I understand with this is when a patient comes with STEMI, and from onset of chest pain to the time you are seeing the patient is beyond 48 hours, and the patient is not having ongoing chest pain, the patient does not have hemodynamic instability, or is not in cardiogenic shock, or is not post-cardiac arrest, or there is no evidence of fatal arrhythmias, such patients should not be revascularized. It's not recommended because at the end, they don't, in terms of outcome, it's comparable to optimal medical therapy.
Okay, so this is what I need you to get because the description you've given looks like for anybody that see a PCI patient and said, oh, yeah, I've looked at the ECG, it was STEMI before, he had STEMI like 2 days, 3 days ago, and it's fine now, and it doesn't need to go for PCI. You know, that's like what you have painted, you get. But I'm telling you that is not actually what they are referring to. So what they are referring to is that if somebody had MI 2-3 days ago and is presenting, it should still go for PCI. Now, during the procedure, if you notice that let's say the left anterior descending is occluded and the patient is stable, patient has vital signs are good and things like that, no symptoms, I don't have to open up that occluded LAD. Why? Because it's already an infected area, and even if you vascularize it, you're not going to achieve anything. In fact, you can now have repercussion injury. But during the PCI, I can see any other vessel that may have critical stenosis that is giving a collateral to that occluded area. So it can have a circumflex. So we are giving an example that the LAD is occluded, maybe mid LAD is occluded, but you are now seeing a collateral flow from the circumflex to that occluded LAD. So you have the opportunity of looking at that circumflex to see that there is no critical stenosis in that circumflex. So as if there's a critical stenosis in that circumflex, you have to revascularize that circumflex. Why? Because in a month's time, 2 months' time, if that circumflex gets blocked, that means that the LAD that was receiving collaterals will lose that collateral. The circumflex is now blocked, and the patient is likely going to die. You get what I mean, sir? So what I'm trying to emphasize is that if somebody had that MI 2 days ago, 3 days ago, even though it doesn't have the symptoms, it should still go for PCI. Not because of the occluded artery, but because of any other vessel that is at risk of getting occluded. They should get revascularized. Hope you get me, sir.
And I get you, Prof. Prof, on that basis, some have also pushed for, before going to do such coronary angiogram in